Hello, everybody.
Okay. Dr. Chilengirov is going to present the case.
So our next case is about 83-year-old gentleman who came to us with high-grade stable angina. He has known coronary artery disease, three-vessel disease, and prior anterior STEMI, which was treated with intervention of the LAD 2014. A month later, the left circumflex was also dilated, and 5 years later, dilatation of the right coronary artery was performed, and another stent in the LAD was placed due to de novo lesion in the proximal part of the LAD and in-stent restenosis of the middle part of the LAD. The patient is stable with no changes in the ECG, with preserved ejection fraction, with left ventricle hypertrophy, and with severe aortic stenosis with 40 millimeters mercury mean pressure gradient. He has normal lab, and this is the diagnostic angio. As you can appreciate, there is a patent stent in the right coronary artery. Sorry. Also, there is a patent stent in the left circumflex artery, maybe some lesions in the proximal part of the left circumflex, but not non-severe lesions. The LAD is stented from the proximal to the mid part, and there is intermediate stenosis, in-stent restenosis, in the middle part of the stented segment. We calculated Euroscore 8.33, and we scheduled the patient for TAVR and coronary revascularization. So the floor is yours.
So this is an interesting patient, but it's not that complex. That's why we decided to do this patient.
Can we go back?
Because let me finish. Because there is a borderline in-stent restenosis and some lesions into the circ, which are probably not significant. But we can ask Professor Nair what is their experience, because Cleveland has extreme experience in TAVI procedures. It will be interesting to discuss what is done in such cases, especially in patients with coronary artery disease and which are good candidates for.
So in patients that have had multiple stents like this, or even native disease, unless the patient has a true angina that is exertional, if there is significant valve disease where valve replacement is indicated, then that is usually done, and the underlying coronary disease is basically left to be treated with medical therapy. If the patient does have angina, then you may, especially if the disease is more proximal, then you may want to choose to do the PCI stenting first, because once the valve is in place, it could pose a challenge to get into the vessel with guiding catheter. It has been done, it's not a problem, but it will sometimes pose a challenge. More importantly, if there is significant myocardium in jeopardy, the patient, even if the patient may not have angina, proximal LAD, large circumflex proximal disease, right coronary artery. If the patient has some complications, bleeding, vascular issues, etc., during the TAVR procedure, you may provoke an ischemic syndrome, which might make it all complicated. So you use all that into the equation before you decide on therapy. So somebody like this with moderate stenosis in the LAD, ISR in the LAD, the patient has no angina, it will be left alone. They will proceed with TAVR.
And if you have three-vessel disease, because we have a patient up there with this, let's say, this three-vessel disease, for sure significant, with, let's say, syntax score less than 20, which are doable. Are you going to proceed with...
So all of these patients are discussed in the heart team. If the patient is a surgical candidate and has triple vessel disease and aortic stenosis, patient might go for SAVR and bypass. So it need not, because it is discussed with the surgeon. Now, if the patient is not a surgical candidate, then it's a different issue.
But the patient is the same. I mean, he is over 80,
Yeah.
and his zero score is about 15. Really.
Yeah, but
This is,
but if you have aortic stenosis and if you have triple vessel disease, I don't know whatever the score is, the patient is a surgical candidate, you will still go ahead and have surgery. Because the issue is, do we do all these, fix the triple vessel? Can it be appropriately fixed? Will there be a complication? So then the aortic stenosis then comes into the equation if there is a complication with the PCI. And that has been seen in the sense that a patient has single vessel disease, mid-circumflex, whatever, has very aortic stenosis and the vessel dissects, perforates, whatever, and now the patient is really, really sick and cannot go to surgery. So to avoid all that, if the patient has no clinical syndrome, just leave it alone. But triple vessel disease, if the patient is a surgical candidate, the patient will go to have surgery. It is very rare that the surgeon who's part of the TAVR team will refuse to take the patient to surgery. And this happens with octogenarians. Now, if a patient is 90, etc., and the patient has angina, then it is open to discussion as to what you would do. Is he a good 90-year-old? Very rarely do patients in their 90s go to surgery. But patients in the mid-80s go have surgery if they're good surgical candidates. But clearly the team decides surgical candidate, non-surgical candidate. Their threshold to do PCI before TAVR is very, very high. I mean, unless the patient has true angina. If the patient has true angina, then you do it. Because they also feel, sometimes patients with aortic stenosis have a very limited exercise capacity. And you have a severe diagonal, severe mid-LAD, severe distal RCA, marginal disease. Then you're tempted to fix. Patient has no angina because patient is not doing much. You do the TAVR, now the patient starts to walk 3 miles, now has angina. You can go ahead and fix it. There is that comfort level that we can fix it at that point.
I have a question regarding how you determine that these stenosis are significant?
we haven't determined. We are going to evaluate them because.
The angina could be just.
Of course. Yeah.
Just from the aortic
Absolutely.
stenosis.
Our plan is just to make a functional assessment of this lesion, and we decide what to do. And this was very wise comment from Ravi, because if I continue with this patient, I mean the previous one, he has an ejection fraction of 20, and he has a secondary severe mitral regurgitation. And in our mind, it was the idea is to, this is not this patient, is probably we can see whether he is a good candidate for mitral clipping, and probably see ischemia, because stenosis are really angiographically significant, but maybe functionally not that big. Fix them, probably think for a TAVI procedure, and after that...
This is a very complex thing. There's ongoing management with close association with the surgeon. These are not simple, straightforward decisions that need to be made. Multidisciplinary discussion needs to occur. You can do mitral clipping, but then the imaging people and the structural team have to get together and say, well, this is a good candidate for mitral clipping. It is feasible to do. Otherwise it's a problem. They will not operate on somebody with an EF of 28%.
Our way of thinking is that probably we should see the coronaries if necessary, right, because putting usually we are working with the self-expanding valves, which in a way have an impact on the access to the coronary arteries. And after that, fixing the aortic stenosis, probably this will change the mitral regurgitation, and if the patient has optimal medical therapy, because this is something that we have seen, and not that rarely, that patients, good candidates for from this point, I mean, from echocardiographic point of view, from mitral clipping, when they receive an optimal medical therapy, the regurgitation disappears almost, or it's not that big.
So Yeah, one answer does not fit all. I think to
Yeah.
work, like you are thinking one at a time, it's very, very important as to what the final decision is going to be.
Okay, let's go to the coronaries. What was the proposal of Professor Vasilev?
Just can we see the angio again?
Yes.
What is the blood pressure of the patient?
The blood pressure is 170.
170. So
70.
why don't you give some nitroglycerin and to repeat,
Okay.
for example,
We already
this?
did
We already do that.
But we have another problem, and the heart rate is
Yeah, I see it's
43
around
to
between 30 and
40.
50.
yes, it's a sinus rhythm, but it's a
Yes,
bradycardia.
we see it here, yes, that the heart rate is around 40, let's say so.
40,
And
yes. 45.
is it responsible to atropine? Did you try?
No.
Teste.
But actually, if you have a 170 blood pressure, this heart rate is not so amazing. However, if you plan a functional evaluation, it will be a problem because
With the
any microcirculation vasodilatation requires some medicines which will decrease the heart rate. Maybe placing a pacemaker will be, or you can rely only on the
No, we are trying
non-hyperemic indexes.
The
This
idea
is-
is
Yes.
to do
Yes.
RFR, in fact.
RFR.
Because if you see here, it seems there is a more, let's say, well-seen stenosis distally of the stent, but the whole proximal part of the AOD is diffusely diseased, and another thing is that the AOD is a very big vessel. It is going over the apex, and probably this, let's say, not that severe stenosis can be a long one, and additionally a serious stenosis can be a problem. And I think it is worth of doing the functional assessment, and after that we are going to proceed and decide what we are going to do with this patient.
To the stent, the LED is twice the diameter of the
Yeah.
FR.
and this is a long lesion.
FR.
For me, this is significant, but IFR is
IFR, yes, but I think that everything from this small second, third diagonal to the ostium will be. No. I think IFR is best at this situation.
Okay.
The problem is what we will do if
Yes,
afterwards.
that was my question. If the IFR or RFR is positive, what will be the next step?
We are going to discuss this with the cardiac surgeons, because this patient is a good candidate for surgery, because he's
In Massimo, my colleague, is that when they are in proximity and they have a tight lesion, proximal lesion, I mean LAD or left main, or even a very dominant right, we do something before the procedure. And through transradial, so normally you have no risk of hemorrhage. And after that, they do the day after or just after the procedure. If it's quick, they do the valve. But for if the distal lesion like the one we see in LED or in CIRC, don't touch it.
Maybe surgery for this patient will be.
Valerie,
yes.
how much do you believe in this functional assessment in patients with aortic stenosis?
This is an interesting question, but I would say enough, Juan-Pros. Good to hear you. I believe enough.
Because I believe none.
Yeah.
Now you will know the difference between proximal and distal to the lesion. After that, maybe you have to include something for the valve.
And in any way, from what I see here, I don't think that's a sort of a very sort of important stenosis. Possibly it's a diffuse vessel, the diseased vessel, but in that case, you will not gain anything from surgery either. So why do you bother about this lesion there? Fix the valve and forget it.
Yes, this
The
is
diffuse-
so put the valve and forget it.
That's what I would have done. I wouldn't bother about that. And especially with this functional assessment, which possibly the RFR is makes some sense because does not use any sort of does not dilate the coronary bed, which in any case has been dilated because of aortic stenosis. So you can't dilate something which is already dilated, so you will not achieve a lot. RFR, if it's because you don't use it, you don't use any dilated drugs, it's good enough. And also, if you have somebody with aortic stenosis, how comfortable you feel to give something which is dilates the arterial tree.
You're absolutely right, but still we have to decide. We cannot put this patient on stress echo. I mean, the possibilities of evaluating this lesion is, and I'm pretty sure I will have some concerns if I have to treat this patient with valve, TAVI, and have a proximal AOED.
You don't have a proximal lesion there.
I mean, there is a tight, not tight, but there is some stenosis into the stent, which is previously implanted stent, which is implanted from the ostium of the AOED.
Yeah, but the other option is to use balloon expandable valve, like that you don't compromise the access to the coronaries and you're completely fine.
Yes, which probably will not affect the access to the coronaries because I'm not sure we haven't done the CT evaluation for the.
With such expandables and its own, sometimes it's not easy to go to treat even the proximal lesion.
Absolutely.
Left main or
Very often you are staying outside the ostium of the coronary, and you have a total lack of support and everything.
No. So.
Какво правите, Върване? What are you doing?
We place the wire pressure.
Mm-hmm.
We place it distally. And can you see the RFR?
Where it is?
No, but let's okay. Let's stabilize and let's measure it. Just press the boo.
Yes.
And where is the wire? We cannot see.
Here is the wire.
Distally enough.
Can you push it a little bit, maybe 1 centimeter distally? 1 centimeter distally from this. Okay, excellent.
Okay.
Okay, I will measure another.
In the gray zone. In the middle of the gray zone.
Maybe you can go out from the gray zone if you give nitroglycerin now.
And try to do a full back now.
No, what we are doing,
the jump.
one process is absolutely right. We have the possibility to record the pullback, and we are going to see where is the maximum.
If it is
okay, we will perform the pullback.
Record it.
Okay.
Okay.
Now you see that the distal pressure, it is coming more and more. Probably we shall see where is the biggest. Here.
Yeah, there's nowhere any big one. It's a gradually sort of improving without any of them being independently significant. There's no any great jump there, I can tell you.
We do not have any jump of the pressure.
No, but if we can see these two small jumps are distally and not away from the instant rest stenosis that we are in fact evaluating. And finally, the RFR there is around 0.995, which probably means that the main contribution to the ischemia is probably of these peripheral lesions, which, in my view, have not interest for these patients for the moment.
Yes.
That's great.
So let's do the valve, Valerie.
For the aortic stenosis. Okay, so I think this is the it was a simple but interesting case. The circumflex is not of importance. No. This is what Yves said. The right has no big stenosis, so I think we have done the case.
Can you see any, Valerie, can you see any calcium in the aortic valve? Because I can't see anything from here.
Yes, it is calcified according to echo, but still we are going to do. Can you see the calcium?
Yeah, I can't see it now.
Yes, but we of course going to evaluate with CT and after that take the decision.
It's a good chunk of calcium because sometimes these lesions are fibrotic and although they look at echo that they are quite sort of dense, when you do the CT. That's not as dense as you imagine. And this are not easy cases.
Is it high or low? Because then that may depend on the...
you have to measure.
Yes, but when the CT, we do the CT and...
interest here to see if it's
okay.
low, then...
Okay.
I think this is for today. Thanks. It was a wise selection of the case. So I want to thank all the faculties which are around me and WAMPROS. We are very pity that you are not with us. Hope that everything is fine with you. You seems to be in a shape. That's great.
And next year we will wait you here on board.
Be here.
We will, if it's necessary, we will come and bring you here. So, see you. Hopefully, see you tomorrow for the discussion of the case, 5 cases, and other interesting topics in the program. And wish you a good night, and see you tomorrow.
Thank you, everybody.